Wonderful. Thanks very much. Well, welcome everybody. I'm Jay Earls. I'm the Chief Medical Officer here at Cleerly. We have, we hope, a very interesting and informative program for you here today, discussing our newest product, which is Cleerly ISCHEMIA. So to start off, I'd like to introduce our first speaker, Maros Ferencik. Maybe probably somebody, very few of you don't know, but Maros graduated from Cormius University in Bratislava, Slovakia. He's one of the graduates of the MGH Cardiovascular Imaging Fellowship. He's currently at Oregon Health Sciences University, where he's a professor of medicine and radiology and section head of cardiovascular imaging. And he's also the president-elect of the Society of Cardiac CT. So thank you, Maros, for being here, and please take it away.
Thank you, Jay. Thank you, FSCCT, for preparing this webinar, and thank you, Cleerly, for sponsoring this educational activity. Hopefully very informative for our viewers today. I will talk about a review of recent studies involving Cleerly ISCHEMIA. These are my disclosures. So when we get the patient into the clinic, cardiology or internal medicine, the patient has symptoms or signs that are suggestive of obstructive coronary disease, two main questions usually arise. And these are, does the patient have obstructive coronary artery disease, and does this patient have ischemia? And the guidelines deal with this with recent 2021 multi-societal guidelines, and they actually give coronary CTA class 1 indication for the evaluation of patients that present to the clinic with stable chest pain and have no known coronary artery disease, with the focus on anatomic detection of stenosis. That's really the main focus of the guidelines for the coronary CTA. And indeed, coronary CTA works very well for it. These are the composite data from Johanni Knuti for almost 30,000 patients, where you see the sensitivity to detect obstructive coronary disease as compared to gold standard of invasive coronary angiography. They're very good sensitivity. Specificity is decent, I would say. Where the coronary CTA struggles is when you compare actually to the functional assessment of stenosis. When you use invasive FFR as this gold standard, you can see really specificity goes to around 50%, sort of toss coin, and really sort of guessing whether this is hemodynamically significant stenosis. And therefore, I think it's really important to take the holistic approach to assessment of patients and use the coronary CTA data in all what we have available. And this is the concept that Sean, Rula, and Min proposed many years ago. When we are looking at a patient with suspected coronary disease, we have to look at all the components, at plaque, which is the largest group of patients, assessment of stenosis, and detection of ischemia. So how does Cleerly ISCHEMIA perform and deal with this issue, and how does it take this holistic approach to the detection and assessment of coronary disease in clinical practice? Very recently, the Cleerly AI-QCT ischemia algorithm was presented, and data were published as we will review it. When you perform the AI-QCT ischemia algorithm, you perform for Cleerly lab analysis, which many of you are familiar with. You detect coronary arteries, you detect the lumen, you detect plaque around the coronary arteries, and you get multiple metrics from this analysis. Now, what AI-QCT ischemia algorithm does, it takes measurements of atherosclerosis, such as plaque volumes, lesion lengths, and so forth, measurements of stenosis, such as diameter or area stenosis, and overall vascular morphology of the entire coronary trees, vessel volume, lumen volume, puts this data into machine learning algorithms. And these data then were trained on clinical data sets with the gold standard of invasive FFR, and then comes and actually give you the binary output per vessel, where Cleerly ISCHEMIA algorithm gives you, is this vessel likely or unlikely to have FFR less than 0.8, being abnormal, or more than 0.8. In more detail, it works again. You can see that when you take the CTD data set, you go to Cleerly Labs, you perform what many of you are familiar with analysis of the entire coronary tree. You, of course, check for anomalies, stents, exclusions, other reasons why you cannot really evaluate these coronary arteries. And then you perform the analysis on the segmented vessels. You put the data that you get from plaque, vessel, and vessel morphology and volumes and lumen assessment into the algorithm, prediction algorithm with some post-processing rules. And eventually you will get a result with the Cleerly ischemia index, and therefore is the abnormal FFR in the vessel likely or unlikely. This type of algorithm leads to a very low rejection rate, and this is driven by the fact that the algorithm is applied for each vessel separately. If you have multiple data sets, you have, best data set for the right coronary artery, let's say at 65% of the R interval and your LAD at 75%, you can put these all together and get really high image quality if you have high quality, of course, in your CTA lab. This, as I said, leads to very low rejection rate and ability to perform analysis in majority of the patients. You perform the analysis at each vessel level, and it's a composite of all the vessels. So if you, let's say, evaluate the obtuse marginal branch, you actually have a composite of the obtuse marginal, first obtuse marginal, but also information from the proximal LCX and the left main coronary artery. So your prediction of ischemia for each vessel is composite of the plaque, lumen, and vascular measurements from all these components. And in this case, again, your prediction of this algorithm results from ischemia being likely or not being likely in the entire vessel in all these segments that are involved in the analysis. When you look, what are the features that are predicting the presence of ischemia? This is the list of all those features. As you can see, there are important anatomical, typical, or known measures such as percent diameter stenosis, percent area stenosis. But then you have the other measurements, such as how many of those stenosis, how diffuse the disease is, and of course, the plaque measures as well are contributing to the prediction of the presence of ischemia, which we know from the previous literature, and really sort of attests to this holistic approach to evaluation of coronary disease that I had on one of my previous slides. In the next couple of slides, I have examples how this works in the clinical practice. Oh, I'm sorry, I'm going to skip. This is a comparison of the ischemia, AI-QCT ischemia from Cleerly with the computational fluid dynamics assessment. As I mentioned, from the name, it's clear AI-QCT ischemia bases the prediction on AI and ML algorithm versus computational fluid dynamic simulation that's performed with FFRCT. Results are reported at vessel base for AI-QCT ischemia and is a binary prediction. Is the ischemia in this vessel likely or not likely? Whereas in FFRCT, you have a continuous variable of the entire coronary tree. You have, therefore, location dependency for FFRCT, not for ischemia. However, in AI-QCT ischemia, you have concurrent visualization of the entire coronary vessel, including the plaque and lumen assessment. So you are evaluating the presence with the entire background of stenosis and plaque assessment. And because you have the specific vessel site for FFRCT, you sort of measure it in exactly same exact spot for as I mentioned before. So how it works, I'll show you in the pictures. Here's an example of a patient that has multiple stenosis, pretty severe stenosis in the proximal RCA based on diameter stenosis measured at 76%. But then you have additional lesions in the mid RCA and distal RCA. So again, the algorithm takes into account all the information about the vessel length, lumen, as well as anatomic information on plaque, and provides the prediction of the ischemia. And in this case, mostly because of the diffuseness disease and extent of disease, it gives you an outcome that RCA ischemia is likely. You have the next case where, the stenosis in the proximal RCA is there. The algorithm calculated at 63%, visually sort of very close, very similar to the other one, but there's less diffuse disease. There's one mild stenosis in the mid RCA, but the rest of the RCA looks much healthier, less plaque, much larger lumen overall, and therefore at the end of the analysis, the ischemia in this vessel is unlikely. Again, using this composite assessment of plaque, stenosis, and vascular morphology to predict the presence of ischemia. How does this algorithm actually work in clinical practice. We have now the initial derivation and validation data set and some data on the clinical assessment that I will review today. So the original derivation and validation of AI-QCT ischemia was performed on 2 large clinical studies, Credence and Pacific. In Credence, we had over 600 patients, and this population was divided into the derivation and validation cohort. The patients had all invasive coronary angiography and invasive FFR and FFR-CT, and some of them even had myocardial perfusion imaging. The reference standard was set for invasive FFR. So we had the gold standard of invasive assessment to develop the model where we were able to predict the presence of ischemia in each of the vessel and each of the patients. So the analysis was performed both at vessel level and patient level. The data from Credence, as I said, were divided into derivation and validation. So there was a validation cohort, another 305 patients where we validated the results of the data. And then another study was taken, Pacific 1, and that was 208 patients where these were used for external validation of the results. We already talked how the algorithm works. So again, the vessels were fed into AI-QCT, the segmentation of the vessels was performed, and then the prediction of ischemia at the patient and vessel level was performed. And these are the results from this initial validation. So this is the validation and the credence, both per patient and per vessel territory. You can see good sensitivity in per patient sensitivity of 85% and specificity of 56% with overall AUC of 0.80. So very decent. And credence per vessel territory 77 and 82% with even better AUC in the validation cohort, which is very good at the validation in per vessel territory. Sorry, I'm just going to skip to the next one, which is the validation. So again, we took the results of the derivation cohort, put it in another data set, of an independent data set. And as you can see, the data are even better or sort of similar to better when per patient you have sensitivity and specificity at 92 and 70% with AUC of 0.85. And in Pacific per vessel territories, 76% of sensitivity and 84% of specificity with overall AUC of 0.86. These data are slightly better, or for some per vessel similar to the FFR-CT algorithm, that overall slightly better numbers as compared to CFD results. These data that were taken, or these analyses were taken to clinical practice, and we have now reported data from 2 different data sets from Cedars-Sinai Heart Institute, where they studied 35 patients. All of them, again, referred to invasive coronary angiography, and they had 42 vessels with FFR or IFR as the reference. And you can see that both per vessel and per patient analysis come with very similar AUC values, so confirming very similar values, and as compared to FFR-CT, similar results as well. So in this data set, FFR-CT and QCT-based ischemia algorithm had a similar AUC values. Another group from Scripps Clinic reported recently 44 patients and 54 vessels. All of these, again, had invasive FFR as the reference. And as you can see, the use of AI-QCT in ischemia improved specificity, especially, and the overall AUC value as compared to both anatomic assessment with CAT rats and FFR-CT. So overall, these data from the derivation of validation show that AI-QCT indeed can predict the presence of ischemia by invasive measures, and can be deployed in clinical practice in these sort of smaller initial experiences. How does the application of AI-QCT-based ischemia analysis sort of deploys in the clinical application? And a certain study answered this question. This is a study from 5 centers that are very experienced in performing coronary CTA. Overall, 750 consecutive patients that were referred for clinical CTA. And at each of the side, the clinical interpretation was performed. The readers had available their workstation, the read, they sort of reported cat rats, and then the multiple other questions in terms of how certain or how confident they are about their clinical findings. Then they were presented with the combination of AI-QCT analysis for plaque and stenosis, as well as ischemia algorithm results. And as you can see on the right-hand side of this slide, when you compare the physician confidence before and after presenting data of AI-QCT, you can see for all the measures, in additional imaging, CAT rats, plans for intervention, plans for medications, or assessment of overall plaque burden, the physicians reported being more confident in their results after presenting with AI-QCT and AI-QCT ischemia. Specifically, where these changes were in terms of CAD rats, you can see it was mostly in this low-level CAD rat score when there were more patients found that were in CAD rats 1 category. Interestingly, there was not that much sort of reassessment in the higher CAD rat score, and very similar for the plaque assessment. It was with a smaller amount of plaques when the algorithm picked up sort of mild or very, very mild disease that was missed by regular clinical reading. In terms of the efficacy of the clinical assessment, there were multiple changes. In terms of additional testing or intervention, there was overall increase in number of patients that after the CTA with AI-QCT and AI-QCT ischemia, there was 7.2% less patients that were requiring additional testing or interventions. This was mostly driven by the less need for additional testing. When we asked the readers initially, 5.8% need additional stress test, 18.8% needed additional FFRCT, and this was overall decreased by 37.1% if we presented data from AI-QCT and AI-QCT ischemia. Similarly, for interventions, there was decrease in the sort of need to do further changes or change the management and increase the basically security of the patients to either recommend PCI or bypass surgery, and less patients that the decision was not sort of clear. So these results, again, confirm that addition of AI-QCT and AI-QCT ischemia can increase the clinical certainty of patients that they can provide the decisions for the patient without need for additional testing. When we deploy a test, of course, we are interested how it performs in predicting future events. We are making the decisions patients at the moment when we are performing the test, but we are also interested what happens to the patient in the years to come. We have now growing data showing that AI-QCT ischemia is very valuable in this area as well. A large study from Johanni Knuti and Turku group analyzed 1,880 patients that were called to the coronary CTA, had coronary CTA performed as their clinical practice, and after that, AI-QCT analysis was performed. In that group of patients, there were 509 patients that actually had AI-QCT ischemia positive, and 1,370 patients that are AI ischemia negative. As you can see over the course of the follow-up of up to actually 14 years, but median follow-up of 6.9 years, there is clear discrimination of risk of major adverse cardiovascular events that included death, myocardial infarction, and unstable angina, with unadjusted hazard ratio of 3 and adjusted ratio of around 2. So in adjusted analysis, including the assessment for coronary stenosis, there's a twofold increase of risk of having major adverse cardiac events if you had AI-QCT ischemia. When you look a little bit more in detail in this table, you can see that when you had a clinical model, so the clinical risk factors that had moderate sort of performance of the AUC of 0.71, basically, which increased after you add stenosis, and had a minimal increase, although not statistically significant, when you added AI-QCT ischemia. When you looked in more detail, however, in multivariate analysis, the AI-QCT ischemia was still an independent predictor with approximately 1.5-fold increase of events in the multivariable model that included 50% stenosis, showing that this provides some additional information for discrimination of patients at risk. What is important is to actually which group of patients AIQCT really works. And what is interesting in this study, it was the patients that had non-obstructive disease and did not undergo revascularization. These were the patients where AIQCT actually provided additional predictive value and higher hazard ratio of around 3 for predicting major adverse cardiovascular events. Johanni Knuti and his group also analyzed a subgroup of patients that underwent 15-0 water PET study, so the myocardial perfusion study and detection of ischemia by PET. And they then looked in the patients, again, AIQCT ischemia positive and negative, stratified by the presence of ischemia. And what was very interesting in this study showed also that it was the patients that had normal PET perfusion and probably less likely to go invasive assessment and invasive revascularization. Those were the patients when AIQCT predicted future cardiovascular events. In composite, again, bringing this holistic approach to assessment of coronary atherosclerosis, coronary artery disease, where plaque, assessment of the lumen, assessment of vessel morphology, combined with the assessment for ischemia probably provides the strongest predictive value and allows us to pick up the patients that may not have completely abnormal vessels, don't need a PCI, but need actually higher preventive measures and higher treatment to actually prevent these adverse cardiovascular events. Specific one trial that the data that I already showed you for derivation and validation also had a follow-up, actually had a follow-up for 8.5 years. And in this data set, AIQCT ischemia was the strongest predictor of future cardiovascular events. You can see a 7.6-fold increase of major adverse cardiovascular events in those who had abnormal AIQCT ischemia, consistent with the other data that we see from the Turku study. So in conclusion, clearly AIQCT ischemia is a validated method with high diagnostic performance against the reference standard of invasive hemodynamic assessment for the vessel-based and patient-based detection of ischemia. It's in some studies similar or slightly better when compared to CFD-based analysis. It has a potential to increase diagnostic certainty and decrease secondary testing when added to anatomic assessment, and has a strong predictive value for future major adverse cardiovascular events. With that, I want to thank you for your attention and pass the baton to the next speaker.
Thank you so much, Maros. The next speaker will be Yader Sandoval. Yader is an interventional cardiologist at the Minneapolis Heart Institute. He's also at the Center for Coronary Artery Disease, and he's an adjunct associate professor at the Mayo Clinic. Yader?
Thank you, Jay. Let me share my slides here. And again, thank you to FSCCT and Cleerly for hosting this educational event. So that was a great introduction on the the diagnostic application of CT. As noted, I am an interventional cardiologist, so I'll be addressing here over the next 15 minutes or so how we shift from diagnosis now to therapy and to triage, and how to use this, particularly how we apply this in applications in the cardiac catheterization laboratory. Think about this. I want you to think about the approach we have had now for about a decade for diseases such as aortic stenosis. If you have severe aortic stenosis, you have a very strategic, multidisciplinary, comprehensive evaluation. As shown here in this timeline, you go to a dedicated valve clinic, you get a planning TAVR CT, you see structural, interventional cardiologists, cardiac surgeons, so on. You have a meeting, and by the time you do your TAVR, you already know where do you want to go, what axis, what valve size you need. You even have an idea of the coronary disease, so you have a very comprehensive approach. For coronary interventions, for coronary artery disease, for a multitude of reasons. We have historically not done that. It has been mostly an ad hoc approach of let's pretty much see what we have to work and identify in the cath lab. And while often many patients have CT, again, for a variety of reasons, historically, most interventionalists in our community have not really harnessed the power of the information within the CT, and therefore we have really probably underused the power of this information to allocate cases to appropriate locations, to operators, to timing based on complexity, and even anticipate what sort of equipment we need. With that, and on our practice, and many others around the world have gradually better visualize the value of incorporating CT-guided PCI approach, in which we're saying let's look at the CT information and understand how we can incorporate that information to understand, is this a simple or complex lesion, and therefore better understand where should this case be done, who should do this case, should it be a complex coronary operator, and of course if there's complex coronary disease or not, you can potentially estimate, is this going to be a 1-hour case or a 3-hour case, and what sort of equipment we need. So we really think about this sort of like where, who, when, and what. This slide summarizes what we're talking about. As you can see on the left, it's pretty much a very focal disease in the RCA. This can be done at any location by any interventionalist ad hoc, whereas on the right, you can see very calcific disease across the circumflex, ostial coming all the way to the left main, more complex coronary artery disease. So you can see how this is something that, even though it seems obvious, we have really not historically used this to triage cases, and there's tremendous opportunities because you can differentiate, again, how to best triage these cases to which location, operator, timing, and equipment. Now let's bring this to interventional applications. There's a lot of lessons that we already know from the vast experience of intravascular imaging over the past decades, years. There have been multitude of registries, trials, prospective experience, and we now know from intravascular imaging perspective, with the primary tools being often tools like intravascular ultrasound or CT, what is the information that we as interventional cardiologists value the most to guide our procedures. And those have been lately and elegantly summarized by this approach that people refer to as MLD, morphology, length, and diameter. And with intravascular imaging, we know how to reliably and consistently get that information. What is the morphology? Is the lesion calcific? What is the length of the lesion? And what is the diameter? And therefore, since we know this information, and now we have better technology, better scanners, software to interrogate all these things, the question is, can we now extrapolate and apply these lessons that we know from vascular imaging to CT to better guide our procedures? So again, if you think about this now with CT, you can really answer a lot of these questions. You can address what the morphology is. Specifically, we want to know whether the lesion is calcific. That's tremendously important because it really differentiates, as shown here in A and B, whether you can just get by with a balloon or whether you need more sophisticated calcium modification strategies. Same thing, we want to know the length of the lesion, and we'll talk about how some of these emergent AI-based approaches can provide really automated detection of the lesion length and even CTO length. And of course, get also a sense of diameter. That comes with some caveats because, there's some limitations that not everybody gives a standardized doses of sublingual nitroglycerin across cardiac across CT scanners protocols. But again, you can at least get a hint of what is the minimum luminal diameter, so you get a sense of what's sort of like your balloon that you can use to implant that stent. So if you really think about this, there's a lot of information that you can use to better plan procedures. So I want to go now. We've heard a lot of data, but I really want to make this practical over the next few minutes as to how we can use this in patients with coronary disease that I refer to the cath lab. So this is an elderly female that had some angina, underwent a CT. This is an extract from one of our CT reports. It raises concern for LAD stenosis, and the patient is referred to the cardiac catheterization laboratory in that context. This is an overview of the diagnostic approach that could be summarized, in which pretty much this 2x2 table highlights nicely, as the reader did, that there is primarily a one lesion over 70% in the LAD, and that lesion per AIQCT is about 74%. So you know where the problem is, and as you can see nicely here, you can just scroll down very easily and understand where is the problem, and you can see it right around there. That's where the lesion is when you scroll down in the multiplanar reconstruction. An advantage of this is that it's very facile. You don't have to be an expert CT user. And again, for us as interventional cardiologists, we're not level 2, level 3 readers. This is a relatively facile way to interrogate the vessel and understand, all right, where is the problem? Is it focal? Is it diffuse? And what's the severity of the stenosis? Now, if you think about all the steps that I talked about now for intervention application, you can really think about how can you we can better prepare our procedures. So what do we care as interventionals? Well, we want to know what guide we need. So so if you go to an axial view, and you can see here, easily you can understand the takeoff of both the right coronary artery and the left coronary artery system. And again, usually the RCA would come about 11 a.m. and the RCA would come about 3 or 4 p.m. So you know where they come, 10 or 11 or 3 or 4. So if they are off it, you know, is this more of an anterior takeoff? Is there a congenital anomaly? You can look at the multiplanar reconstruction and see whether there are branches that are important. And in this particular software, nice thing, as you can see here with that red line, is that you can nicely see how you can identify pretty much a co-register deletion that is the most tight lesion, that 74% that we previously identified, as seen here by this tracker tool at the middle AD, in combination with a 3D model, in combination with a straight multiplanar reconstruction, and see it across various formats. On that same token, and I'll show this in a practical case, you can also look at one of the small multi-panel views that allows you to understand on the green line the distal vessel, and on the red line the proximal vessel. And similar to what we do with intravascular imaging, you can identify then on the cross section where is the healthy landing area, both distally and proximal, to get a sense of what is the potential estimated length stent on the basis of a healthy to healthy landing area. And importantly, and I really want to emphasize this, this is probably for us in the cath lab, this is one of the key issues, is the lesion complex on the basis of calcium. And as you can see, there's pretty much a one-click facile tool that you just go to the cross-section of where the disease is, just click plaque overlay, and you'll see whether this is yellow or blue. If here you can see this is yellow, so this is not calcified. So this is something that we can treat easily with a balloon. Whereas if this was a blue donut, that would mean that it's very calcific, and therefore you would be thinking more about calcium modification strategies. But you can really see how you can really come up with a game plan in which you say this is a focal middle AD lesion distal to the diagonal, and you can treat this with a balloon-based strategy and anticipate that you may need a stent about 15 millimeters or so. So again, this is just how you can really put this whole game plan even before you come to the cath lab. And arguably, this is a very valuable information for us in the cath lab. I want to show at least one of these cases practically, step by step. I may skip the other two for the purpose of time, but I do want to show here what we're talking about. So as you can see here, when you start analyzing this in the platform, you're going to usually start in the RCA, as pointed here on the left, and then you already know, again, you're tackling this from an interventional perspective, not from a diagnostic perspective. So again, from an interventional perspective, I don't need to look at the right. I don't need to look at the circumflex. It's already been consistently reported from a diagnostic perspective of multiple modalities that the problem is in the LAD. So I'm just going to go to the LAD tab. There's the LAD tab. Nice thing is that you can, again, same as you can do with any traditional CT software, you can window level to make sure that it's not too bright and to your liking. And here, as you can see, you can pretty much go to this two-panel axial view and nicely identify where is the takeoff of that left main and the RCA. For the left main, you can see the length of the cross-section to get a sense of whether you need an XP35, an XP40. And similarly, you can see where's the takeoff of the right coronary artery to see whether you need a regular JR4 guide or like an AL guide if it's too anterior. So now you've identified, again, which catheters you need. Now go to the lesion. Here's a multiplanar reconstruction. You can see this on either the curvilinear MPR and rotated to see the lesion, or you can look this in the straight MPR. For us in the cath lab, I think the curvilinear MPR is something that we understand better. And easily, you can just scroll back. These are all segmented to you and identify where the stenosis is. And as you can see there, right at this particular point, that's a 74% AIQCT stenosis right in the middle AD. And again, we're not level 2-3 readers. So if you're confused about where you are, you have a 3D model here that has this red orbit that shows you that's where the problem is. So you know now that there's a middle AD lesion. It's distal to the diagonal, and this gives you already landmarks. As I said, and I'll pause this here just for 1 second and just go back to show that there's this plaque overlay tool. So if now you're at stenosis, you just hit the plaque overlay tool. And as you can see, this is pretty much yellow lesion, which means non-calcified on colorization. So this is something that it's not calcific and will likely respond to a simple balloon. So now again, you know your guide probably like an XP35. You know this is a focal lesion in the middle AD. You know that there's a diagonal that you may or may not want to protect. And then and you know this is something that you can treat with a balloon. Last, you want to get a sense of what is the length of the lesion. Here, just rotating through the MPR. I'm going to advance this a little bit more. And here, for the length of the lesion, if you go to this multi-panel view, you can find now two of this orbit. It's a green one and a red, and you can pretty much manipulate them to understand where is the distal healthy reference vessel and the proximal healthy reference vessel based on similar to what we do with like IVUS or OCT. And you just scroll through both of them to find where those healthy segments are, and pretty much where you can go pretty much and say, well, I want to cover from healthy to healthy, which is what we usually do in the cath lab when we're doing PCI. And therefore, based on that, you can drop a length and pretty much get an estimate as shown here on the multiplanar reconstruction, how you're trying to identify those two healthy segments. And then subsequently, you go to a distance tool that I'm going to show right there. And once you click the distance tool, you can pretty much just get a sense that this is probably about a 15 millimeter stent that you want to place. So again, this summarizes how you can use CT to really guide your procedures in the cath lab. And lastly, as shown in the 3D model, you can get a sense of where that stent would be placed in between those two diagonals from there to there. So if we go back to this summary, you have the whole approach. Focal middle adhesion, this is relatively non-complex. Any operator can do this. You can do this at non-surgical backup lab, ASC, or hospital-based lab. You know that right's a little bit anterior, and you need an AL1 guide, and you know that you can treat this with a balloon speed strategy with a 50 millimeter stent. This is what was done in this case. You go up front with a guide, as demonstrated before. You can see a very focal lesion in the middle AD as we anticipated, treated with a 15 millimeter stent with an excellent angiographic result. The one caveat, as I said, at this particular point in the field of CT that we're still learning is that with CT, it's often perceived that as compared to intravascular imaging, some of the measurements that we get a little bit smaller. So here, as you can see, we put a juicier, larger stent, 2.75 millimeters. So we're still doing a lot of imaging intravascular to select the stent size. But you can get a sense of what is the balloon that you need. And this is something that's an opportunity for the field to better understand the stent size. Switching to case 2 here, I won't go over all the approaches. We just discussed it at length, but I do want to highlight again that this is another patient that had anginal symptoms. Now, another LAD. So I want you to compare to case 1. In case 1, it was a focal, straightforward LAD. Here from the case overview, same example, you would say, oh, it's the same lesion. It's an LAD, just one single vessel coronary artery disease. But even from the case overview, in the summary here in the multiplanar reconstruction, you can already easily appreciate that there's way more calcium there that's present. So now if I scroll down and go to to our plan, you will get the same approach that, yes, you may need an AL guide, but now I want you to appreciate how from an interventional perspective, Now, this case is totally different. As you can see here, now the most severe lesion where the tracker tool is, it's actually at a bifurcation into a decent sized diagonal. And if you don't know where you are, again, we interventionalists are not level 3 readers. You just go to the tracker tool, find that tight lesion, and now you can see in the 3D model, not only is it tight and calcific, but it's right at a large diagonal. That's an important perspective because now you're thinking maybe you want a potential 7 French guide. Maybe you want to protect that side branch with another wire. And now, critical, as I said before, a particular tool it's a particular piece of information that is very important for us is, as I said, is case complexity. So now if we go to the lesion, do the plaque overlay, as you can see, that plaque overlay as compared to the last case that was a yellow lesion circle non-calcified, this is a blue donut. This is a very severe concentric calcification. This is now different. So this case now needs to be done at a primary cath lab that has calcium modification strategies to deal with this calcium, somebody that's comfortable with bifurcation coronary disease, and you need 2 wires. And you can see here, same thing. You can get estimates based on plaque on healthy to healthy lending areas as to what stent you might potentially need. I really want to underscore that, at least from our perspective, the assessment of calcium, it's increasingly a very important aspects. And you can see here, non-invasively, clearly this is not the, this is not for us in the cath lab like what we're often seeing on let's say, OCT or IVUS, but the pattern of calcification, it's very easily can be appreciated in a similar format on CT. And as you can see here, this is circumferential calcium. This needs to be treated differently. So now if you put together the plan for this case, now this is a complex lesion, bifurcation lesion, calcific LAD. This requires somebody that's comfortable with this sort of disease. You cannot do this at any random lab. You need to do this at a lab that has calcium modification strategies. And you know that you want to protect the diagonal because it's an important side branch. I won't go over the whole details because it's pretty much what we said before, but it's the same step if I go through this quickly, that you essentially go and find the lesion in your multiplanar reconstruction. We'll find the guide that you need based on the axial views. Then you go again to the multiplanar reconstruction, and you can see that there are side branches that are important, involving some calcification. And then here, if you hit the plaque overlay tool, you will find right there that there's concentric calcification. That's an important feature. Last, here's the case. As you can see, severe middle AD as we expected, actually confirming the information from the CT. When we did a balloon here, you can see that the balloon actually did not expand. It has a little bit of a waist. So we actually had to use here intravascular lithotripsy to overcome that calcification. And here's the final result following a provisional technique of the LAD with calcium modification strategy to that middle AD. Last, to wrap it up, an important tool that we're also increasingly understanding from CT, and actually it's one of the few areas in interventional that there's actually a randomized trial of CT-guided PCI in patients with CTO, with data showing that a CT-guided PCI approach and CTOs improve CTO PCI success. So therefore, there are opportunities for us to better understand how to use CT for CTO. Is, again, better understanding the complexity of these lesions before you come to the cath lab. And as you can see, this is just from a traditional CT software, a MIP projection. But now with softwares like this one here from the Cleerly platform on the right, you can see how you can get nice segmentation easily of where that CTO is. But particularly, I really want to highlight this tool here on the right, which is automated CTO detection. That again, you just go to the multiplanar reconstruction that told you there was a lesion. You just click there, the CTO tool, and it will automatically detect you where that CTO is. And if you know where that CTO is, then you can bring the distance tool and measure that CTO length. So now you get a lot of information. You know there's a CTO, you know where it's located, you know the length, and you can further characterize that in some of the both straight and curvilinear multiplanar reconstructions, as well as get a sense of the course of the vessel and whether there's calcific. So again, this is the same case. There's that CTO, and if you just scroll through the CTO lesion, you're gonna characterize that both on the 3D model as well as with respect to whether there's calcium or a soft lesion. And again, this is a potentially important tool because the CTOs are the hardest lesions that we encounter in the cardiac catheterization laboratory. So the more information we have before the case, the more valuable this may potentially be. This is the case, successful CTO PCI of that ramus, shown here on the right, using CT guidance. This is something that there's a lot of interest in our field. We actually hosted the first ever CT guided PCI course in April in Minneapolis early this year. We'll be having the next version on October 24th, 25th. So something that people can learn about. So to wrap it up for CT for pre-procedural planning, I would say that as this is done for TAVR, this is increasingly now being recognized that we should and must appreciate the role of CT to assist with pre-procedural planning coronary interventions. As demonstrated, we can assess case complexity and help with triage of location, operator timing, and equipment selection. And I think we already know a lot of the pieces of information that we're looking for from intravascular images. And now the question is, how do we obtain similar assessments to guide PCI pre-procedural from CT? And clearly there are opportunities for further validation and prospective studies and trials. And with that, I'll wrap it up. Thank you so much.
Yeah, Yader, thank you so much for that. That was very informative. Yader truly is a pioneer in this new field of CT-guided PCI. Finally, our last speaker, certainly not our least speaker, is Dr. Kathy Krol. Kathy is a retired interventional radiologist, past member of the AMA CPT panel, as well as the AMA RUC panel, and current member of the AMA Digital Medicine Payment Advisory Group. So she will be teaching us about the very important issues of coverage and reimbursement for both the plaque code as well as the ischemia codes that are currently available. Kathy.
Thank you, Jay. And thanks everybody for being here. Thanks FSCCT for hosting us. My disclosure is that I am a paid consultant on payment and reimbursement coverage issues for Cleerly. First, I'm going to talk about how you get paid, how you bill for these services. The first one is plaque. If the plaque service is being performed in an outpatient or office setting, the payment is from the physician fee schedule. The codes are currently Category 3 codes, which means that they aren't valued and they're not published as valued in the Medicare fee schedule. These are the codes. There is a global code. If you provide the entire service, you bill the global. Then there are 3 component codes, and these are all carrier priced. So if you're performing that in the office setting, you'll have to negotiate with a payer for coverage and payment. If the plaque service is being provided in a hospital or hospital outpatient setting, there is an APC payment that's been published by CMS for the technical component of it. And that APC is 1511, and you can expect to be paid approximately $950 if Medicare is paying for that technical component. These are the most commonly used ICD-10 codes we see being coded for plaque, certainly not an exhaustive list, and doesn't mean that these would all be covered, doesn't mean that there are significantly more codes that you could use. These are just examples. If you're providing ischemia, the billing for that is a little bit different. Up until January of this year, those codes, FFRCT codes, were also Category 3 codes. But in January, the CPT panel published a new Category 1 code that is now used, and that code is 75580. That code says that this service is a non-invasive estimate of coronary FFR derived from augmentative software analysis of the data set from a CCTA with interpretation and report by a physician. And that is precisely what the ischemia product for Cleerly is. Cleerly ischemia provides a binary indication of ischemia as being either likely present or not likely present, and that's based on the threshold equivalent to an invasive FFR measurement of less than or equal to 0.8 or greater than 0.8. The diagnostic performance, as you've heard, for ischemia was measured against direct invasive FFR, and the binary indicators are based on the societal guidelines for FFR thresholds. The augmentative part means that the AI alone does not give you the final result, and that there is still physician work that needs to be done to further utilize that information into how you're going to clinically care for the patient. And also the final interpretation of the AI report needs to come from a physician. If you're coding in an outpatient, providing the service in an outpatient or imaging center for ischemia, the code would be 75580. If you're billing for the entire service, the RVUs are approximately 27, and you would expect to be paid by Medicare approximately $900. If you're providing only the technical component, you report the same code but put a modifier technical component, and that payment is approximately $870. If you're providing only the professional component, you would report the same code with a 26 modifier, and the payment for that's approximately $35. If ischemia is being provided in a facility or hospital outpatient department, the payment comes off of an APC instead of the physician fee schedule for the technical aspect. The APC for ischemia is 5724, and the payment is approximately $1,000. The professional component for the service in a facility or hospital outpatient comes off the physician fee schedule, just like it did in the outpatient setting, and you would bill the professional component with a 26 modifier, and again, expect to be paid approximately $34. These are the most common ICD-10 codes we see being billed with ischemia. Certainly not an all-inclusive list, but just examples of what might be appropriate. For documentation, because the plaque is still at Category 3 codes, and that means it's still considered investigational or experimental. The documentation requirements are a little bit more than for ischemia at this point. You need to document in the patient chart all the clinical findings that support medical necessity for the CCTA and the plaque. Of course, you need to put a plaque analysis report in. And then the physician part, and this is really important because the physician final read is required, and based on that work is how they will determine how much you're going to get paid for that. And what you need to do is just confirm that the center lines were drawn appropriately by the computer, that you agree with the findings. You must compare the Cleerly report with the CCTA, and if there are discrepancies, if the CCTA says one thing and the plaque report says another, it's up to the physician to explain and resolve, and the final report should clarify which one of those is correct. When you're submitting documentation to the payer, you should submit the plaque report and all the history and physical documenting medical necessity for why plaque analysis was needed for your patient. For ischemia, the documentation in the patient chart is very similar. Body mass index is not required by all payers, but may still be required by some payers. And again, it's up to the physician not to just say, agree with this Cleerly ischemia. You should put in there something about, I've compared the scan, I compared the CCTA with the ischemia, and if there are any discrepancies, my opinion is that this is the correct answer. And when you're submitting the bill to the payer, most payers now don't require any further documentation with the claim, since this is now a Category 1 code and widely covered. Some payers may still require submission of documentation, so make sure you know your own payer. Let's look at payer coverage. For plaque being as Category 3, there are currently no local coverage decisions that address this, but I am very happy to say that at the end of May, all of the Medicare MACs released draft coverage decisions that were positive, and those will be going through the process and should be finalized in the next few months. There are currently 2 MACs, First Coast and Novitas, which have actually published dollar amounts in their physician fee schedules, and these are those dollar amounts. And again, if you're providing this in a facility, the technical component would be the APC of $950. For the other MACs, there is no payment amount published, and we're hoping as we continue through the process of getting the LCDs finalized that we'll also be working with payers to come out and tell you how much they're going to pay. For commercial payers, almost all of the commercial payers are currently silent as to whether they'll cover and pay for plaque. There are at least 3 payers with negative coverage policies saying that they aren't going to pay for that at this point in time, and those are Aetna, Humana, and United Healthcare. For ischemia, because these are now category 1, and that means that the level of evidence has reached a level that these are widely used and considered standard of care pretty much. There are LCDs in place that are positive for all the MACs when the criteria are met. I didn't put the criteria here because they do vary from payer to payer, so you need to know your own local coverage policies and check your local LCDs for specifics. Almost all of the commercial plans have positive coverage policies in place for ischemia, and about 98% of them will pay when their criteria are met. This information is accurate as of the end of May of 2024, and I do want you to know that there are continuing efforts ongoing to expand payer coverage, and there's certainly a lot of ongoing development of evidence to support payment and coverage so that your patients may have access to this technology. Thank you.
Thank you so much, Kathy, for that really comprehensive overview of what is a very important topic of payment and coverage for both plaque and ischemia codes. So we only have a couple of minutes left. We do have one question I will direct to Maros, and that is how do you summarize the differences between FFRCT and the Cleerly ISCHEMIA product?
So differences in diagnostic accuracy, Jay, you said?
I think there was sort of maybe how they work or what the basis of the algorithm is. I think that's how I read the question.
So, I would go back to my summary slide, and I'll just going to sort of read through it, and then I'll talk a little bit about diagnostic accuracy. So again, the method by which the result is generated is different. For AI-QCT ischemia, it's AI-ML-based prediction algorithm that is based on the analysis of the plaque, stenosis, and vessel morphology. And again, as we showed it on the slides, it's fed into the AI machine learning algorithm and the prediction whether the ischemia is present or not based from the derivation and then the validation data set is performed. For FFRCT, it's a computational fluid dynamics simulation where you can segment the arteries and you get a lumen, you perform fluid dynamics assessment and calculate basically the pressure in the vessel and at every point in the vessel. So that's one difference. And then there are a few differences in the output, as we talked about AI-QCT ischemia for each vessel, and then per patient tells you whether or not the ischemia based on FFR, invasive FFR analysis, is likely or not likely. For the FFRCT, you go with the pin and you sort of each part of the vessel determine what the FFRCT value for that particular vessel is. Now, if you have AI-QCT ischemia, in one view, basically, as we showed, is you have all the anatomical information and the likelihood of ischemia. On the FFRCT, you have the coronary tree with all the FFRCT values. And again, on the screen, you can combine it also with the CT information from your reading software. In terms of the diagnostic accuracy, I would be very careful. And if the authors, if the people want, actually, I did write an editorial for the Nick Nur Mohammed's paper, so please feel free to go and read that. There are some differences. There are some values where the AI-QCT is a little bit better with statistical significance. I think there are some sub-analyses where actually FFRCT was just slightly better. You have these data from the sort of performance in clinical practice, where in some it was similar, in some of AI-QCT was better. I think ultimately you would need a prospective study where it's find it. All these results are dependent on how you measure FFRCT. And you can go to the details of the both specific credence. The invasive FFRCT was measured in one of the study in distal vessel, and then another study just distal to the lesion. And it depends how you measure an invasive FRCT. It will affect actually what your diagnostic accuracy of these tests will be. So, I mean, for a purpose of general practice, I would say it seems from the available data that both of these tests provide a clinical answer, which is, is this likely that this vessel has ischemia? And many patients still will need invasive evaluation. At the end of the day, patients go to the cath lab, and whether the non-invasive FFR or QCT ischemia is positive, negative, you can get a contradictory result in the cath lab. It's still possible. You know, the tests are not perfect. Yes. I think the strength of the IQCT is that sort of integration with all the plaque and stenosis assessment in one sort of view at this point. But of course, I would be honest, sort of FFRCT analysis, there's also plaque analysis available from the other vendors. So I think what I would encourage everybody to do is that slide that I have from Jim and from Jared and Leslie, like, look at the coronary artery disease as a complex disease that's the interplay of plaque, stenosis, and ischemia evaluation. Look at the disease that way, and then you will get the right answers for your patients.
Yes, and I agree. Thank you. That's a wonderful summary. And Yader, one question, something that we hear from folks, interventional cardiologists who are using us, is that they find if they do a Cleerly ahead of time, that at the end of the day, they spend less time in the lab, they use less contrast, they have less radiation to the patient, and it makes them more efficient, in addition to all the benefits that you discussed of being more accurate, knowing what you're going into. Do you also find that it's a little bit more efficient because you know what you're getting into prior to going to the lab?
I think that's the expectation. You know, I think we similarly need prospective studies of people actually looking at all this CT information and therefore actually doing CT-guided PCI, which is the whole reason, you know, we've done like these educational courses to try to inform interventional cardiologists of doing that. Because of course, if you do the CT, but you still do your procedure as you've done it all the time, then it may not necessarily, but the whole idea is that you're going to look at this, and to your point, you're like, hey, I already know where the problem is, so I just need one picture, and I know where the actual lesion is, so I can go up front with a guide. And since you have a plan, yes, you are correct. If you have the plan, but you have to look at the CT and be educated on what to look about, then yes, the hypothesis and the expectation would be that yes, your procedure should be more targeted, less contrast, less radiation, and importantly, I do emphasize that issue of complexity, for example, in calcium and others. And potentially, we need those cost-effectiveness studies, potentially even less cost, because you say, I'm not going through 6 balloons. I know it's calcific. I'm going to use an equipment to treat the calcium and better use resources. So yes, I think we need more prospective studies to document that. But I think anecdotally, and the expectation is that would happen.
Great, thank you. And then Kathy, now that we're, knock on wood, hopefully on the verge of national Medicare coverage for the plaque codes, what do you anticipate the timeline for commercial coverage, given that usually commercial entities wait for Medicare coverage? What sort of time frame do you think we would expect for that?
Certainly, we're working hard on getting that as quickly as possible. I would say in the next year, hopefully. It will be payer by payer. And of course, advocacy from all of you who are specialists and using this and telling the payers why it's important for your patients and how it's helping your patients will help get better coverage.
Great, wonderful. Well, I'd like to thank all of the panelists as well as the society and all of you who attended today. We greatly appreciate your support, and I hope everybody has a wonderful day. Thank you.